Hi there, hope you're well. So my name is Michael Freeley and I am an assistant professor in precision medicine in the School of Biotechnology, and I am also the program chair of the MSc in Diagnostics and Precision Medicine. So we do have some availability still on this master's course, so perhaps you are a life science graduate or working in a related field, such as chemistry or pharmaceutics or indeed medicine. As well as that, perhaps you are working in a relevant industry, such as the diagnostics industry or medical field, and you wish to upskill or pivot. So today I'd like to give you an overview of our master's course, and my details are here, michael.freely@dcu.ie. So do feel free to get in touch about any questions that you have. So, as I said, I'm the program chair of this master's program, the Diagnostics and Precision Medicine, and we are now going into our third year in this course, and it's been really, really successful to date. We're really happy with what we have achieved so far, and we're really looking forward to the future. And what this program is it's a hybrid learning program that details how the latest advances in science, technology, and medicine are enabling diseases and conditions to be diagnosed more accurately, treatments to be approached more individually, and that is away from the traditional approach of the one-size-fits-all, where everybody gets the same treatment. In addition, the program gives a broad overview of how we can identify those at risk of developing a disease or condition before it actually occurs. And of course, prevention is always better than cure, so we do cover some of that as well. Our course is available over 1 year full-time or up to 4 years part-time. So there's a lot of flexibility built into the system, in that if you take the course part-time, you can select as many modules as you like in a particular year. And that allows you to tailor the course around perhaps your working environment or your commitments elsewhere. So just for today, I'm going to give you an overview of what precision medicine is, over about the course of 10 or 15 slides. I will then go into our course structure in terms of how this course is delivered, the modules that we deliver on the program, as well as how the program is assessed, or how you are assessed in your learning and your development. Point 3 is how you can apply for the course. I'll also tell you some of the career prospects where our graduates have gone on to after they've successfully graduated. And finally, I'll give you a couple of examples of testimonials from our students. So you'll see that they were extremely happy with this course. So first of all, I'll just tell you what precision medicine is. So really, there's a lot of definitions of what precision medicine is, but the one I like best is that precision medicine is defined as prevention and treatment strategies that takes patient variability into account. So here the key is patient variability, that not all patients are the same. And this variability essentially is capturing people's genes, their environment, and their lifestyles, either one of those or perhaps all of those together, with the aim then of providing the right patient with the right medicine at the right time. And really, precision medicine has come about because there's been a great and better understanding of normal and disease states. So there's been huge advances in molecular and cellular biology, so we now can really drill down into different diseases at the molecular level. And with that, that has led to revolutionary new treatments for these conditions or diseases. And this primarily covers, but not limited to, cancer, inflammatory diseases, and inherited diseases. So in our course, we certainly cover all of how all these treatments, or how all these diseases are now being treated. And certainly in terms of the practice of medicine, we've come a long, long way. Hippocrates is widely known as the founding father of modern medicine. And essentially at that time, over 2,000 years ago, he believed that the body was made up of 4 humors, or 4 substances. This was phlegm, blood, black bile, and yellow bile. And essentially what he believed was that a healthy person that would have a balanced 4 hues, or 4 of these substances, these 4 substances would be balanced in the person. And if a person developed a disease such as cancer, that this was due to an imbalance. And he believed that cancer was due to too much black bile in the person's body. And of course, we now know that this is not true at all, that cancer is primarily driven by genetic aberrations in cells that lead to uncontrolled proliferation. So this better understanding of normal and disease states has now brought us to the modern molecular era, where we are now able to pinpoint the molecular basis of a wide variety of diseases, including cancer and inflammatory diseases, and with that design new therapies to treat these diseases more specifically. And certainly in the last 30, 40 years, there's been a revolution in the new types of medicines that are now on the market. Up till 1982, a lot of medicines were primarily chemical based, so they're made by chemists. These were small molecule drugs. But with the advances in cellular and molecular biology, we've now been able to clone genes that code for proteins and insert that therapeutic gene into a living cell. And that living cell can produce that therapeutic protein for us in large amounts under very controlled conditions. And the first protein that was produced this way was human insulin. It was produced by Genentech in 1982, and it's used to treat diabetes. And recombinant proteins are produced quite easily now at this stage through recombinant DNA technology. In 1986, we had the first approval of monoclonal antibodies. These are these Y-shaped molecules here produced by B cells during an immune response. And while they're very important for fighting immune responses, these antibodies can also be produced to treat diseases. For example, the antibodies can latch on to cancer cells, or they can mop up inflammatory molecules to treat inflammation. And this is an example here of a monoclonal antibody called tildrakizumab, which is licensed for the treatment of psoriasis. And you'll see a patient here with this inflammation in his or her skin. There's red patchy scales here on day 1 before treatment and day 140 after treatment. So a few months after treatment with this monoclonal antibody to mop up the inflammation, the inflammatory molecules, leads to complete resolution of this patient's psoriasis. So again, this is a major step forward in the production of revolutionary new treatments to treat different conditions and diseases. In 2001, we also had small molecule drugs being used to target different, for example, kinases that drive cell proliferation in cancer, and primarily chronic myeloid leukemia back in 2001. And we now have over 50, 60 of these small molecule drugs that are now licensed to treat different types of cancer. Here's an example of a small molecule drug here called vemurafenib. Its molecular structure is shown here. It's used to treat metastatic melanoma. That is melanoma that has spread from the skin to other organs in the body. And you'll see a scan here of a patient on day 0, and the tumors here are lit up in yellow, green, and red. And you see after day 14, just 2 weeks of treatment with vemurafenib, the small molecule drug, leads to almost complete resolution of this person's tumor. So dramatic responses and being able to target a specific pathway that's driving cancer in this patient. And last but not least, we also have the advent of gene therapy, whereby viruses can now be genetically engineered with new genetic sequences, so they can carry new genes that can replace missing genes in a person with an inherited disease, and insert that gene into the genome of the patient. The first gene therapy was approved in 2012, and we now have quite a few of these that are now licensed both in America and in Europe. So really, we've come a long way in medicine over the last 50 years, for example, whereby we can now pinpoint the molecular basis of disease, and with that come up with novel treatments to treat these diseases better and more efficiently. However, against all of these great revolutionary treatments is that the practice of medicine has traditionally been an inexact science, which is interesting in itself. And really why that is that often a diagnosis of condition or disease is still based on patient symptoms. Okay, so a patient or a person may present in the doctor's clinic with, for example, a pain in their back, and the doctor does his or her best to try and make an accurate diagnosis based on those symptoms. So the pain in the back could be muscular, or indeed it may be something more sinister, such as a tumor. So the clinician has to make the best diagnosis that they can based on those symptoms. And with that, a treatment then is usually applied to the patient. And we all know that therapies that are clinically approved for different conditions may work well for one person, but ineffectively, or indeed not at all, for another person with apparently the same condition or disease. So the best example I could give you there would be for cancer. People are treated with chemotherapy to treat their cancers. And we know if you have 20 patients with melanoma and they're all treated with the same chemotherapy, that some patients will do well with the chemotherapy and other patients, or most of them, will not do well. And really, the goal of precision medicine then is to come up with more stratified approaches to treat individuals rather than populations. And really why treatments work well for one person and ineffectively or not at all for another person with the same disease or condition is that therapeutic drugs are traditionally approved based on the average patient. Okay, so when patients are recruited into clinical trials to test a new therapy, you're looking at those population in the clinical trial as a whole, not individual patients, but you're looking at the average patient as to how they respond to that treatment. So when a treatment then is now clinically approved, it may work well for one person and not so well for other people with the same disease or condition. So really, traditionally, therapeutic drugs have been approved and given to patients on the one-size-fits-all approach, where everybody with that disease or condition gets the same drug. And as we know, when patients don't do so well on a particular drug, they may end up going on a trial and error approach next, where the doctor will then try a different drug to see and hope that that drug will have an effect. And if that drug doesn't have an effect, again, remember, this patient's condition or disease may be deteriorating over this time that they've been on these inefficient therapies, and the doctor is always trying to come up with a better therapy and going around on this this roundabout of different therapies to try and treat these diseases. And at the end of all this then, really this is a nice figure from 2001. It's quite dated, but it does show how ineffective a lot of clinically approved drugs are. This shows in navy along here the percentage of the population for which drugs do not work. Now, as I mentioned, take this in mind that this is back to 2001. You'll see that antidepressants were ineffective for an average 38% of the population. Okay, so we'll have 62% of the population on antidepressants will get a benefit from those drugs, but 38% will not. So they will end up perhaps getting a different type of antidepressant to treat their disease. If we go down the list, arthritis drugs. Arthritis is inflammation of the joints. So rheumatoid arthritis is inflammation of the joints. It's a 50-50 chance as to whether the drugs would work or treat that condition back in 2001. So essentially a roll of the dice. If that particular drug doesn't work for this patient, they will usually be prescribed a different drug to see if that works. So again, it's still going on this trial and error odyssey. And if you look at cancer drugs that were approved back in 2001, it's a 75% chance that the drug will not work or will not effectively treat this person's cancer. So up to that time, we can do much, much better. We can make the drugs. We think we know how they work, but they're given to patients and we find out that they actually don't work in a large percentage of the patient population. So we need to be better at pinpointing the molecular basis of a person's disease or condition. And finally, in terms of prognosis, okay, so a patient gets a diagnosis and they'll usually want to find out from the doctor, what is the prognosis, what is going to be the outcome of my disease. And often, as in the case, the prognosis may be unclear. We're going to treat you and we'll just have to wait and see and hope that, everything will be good for you. So in terms of precision medicine, what we're trying to do is diagnose diseases or conditions more accurately, apply treatments more appropriately towards the individual rather than the whole patient population, and also coming up with a better prognosis as to what the outcome of that particular patient's disease or condition may be. So I mentioned this was 2001 data that we had. Has the precision medicine done any better? It has, as I will tell you over the next few slides, but we could still do a lot better, because this is a paper a short paper from 2015 in the highly respected journal Nature. And this shows the top 10 highest grossing therapeutic drugs in the United States. Number 1 is Abilify, and number 10 is Neulasta. These 10 drugs treat a variety of different diseases and conditions. And what they'll show is in blue is the percentage of people who get a benefit from a drug versus the red people here which do not benefit. So I go to number 3 here, Humira, which is an antibody-based drug used to treat rheumatoid arthritis. It makes the company about 20 billion per year in profits. But if you have rheumatoid arthritis and you take this antibody, you're prescribed this antibody by your doctor to mop up this inflammation in your joints, about 1 in 4 patients experience an actual benefit of this drug. So really, despite us knowing that the molecular basis of different diseases and conditions and coming up with very good drugs to treat them, we're still not giving the drugs to the right patients. So 3/4 of patients here will benefit from a different drug than Humira. And that is the goal, really, is coming up with better therapies at the outset for these 75% of patients here, as opposed to the first patient in blue, which will benefit from Humira. And that really is the goal of precision medicine. So to date, we've made quite a lot of progress in precision medicine, but we certainly can do a lot more. And that essentially is what our course is covering. It's all to do with precision medicine and diagnosing diseases and conditions more accurately through molecular analysis and applying therapies more at the individual level. So really we have to ask ourselves, why do we have all this impreciseness in terms of administering treatments and diagnosing diseases and conditions? Well, as I mentioned, the diagnosis of a disease or condition may be based on a patient's symptoms. You know, someone may have a pain in their back, and it could be a number of things. So it's up to the doctor to try and diagnose that condition based on what has been presented in front of them. And science may not have answered all the questions to give an accurate diagnosis to this patient. So the doctor does his or her best to make the diagnosis. Another reason why there's impreciseness in administering drugs is due to pharmacogenomics. This really is essentially as individuals, our genetic codes differ from one another. And there are a number of genes which allow us to metabolize drugs. And some of us have variants of these genes. So some of us metabolize drugs quite quickly. So if we metabolize a drug quite quickly, we may need actually a higher dose of that drug to get a benefit. Whereas on the other hand, a person who has a genetic variant in this particular gene that metabolizes a drug, if they metabolize the drug more slowly, well, they will likely need a lower dose of the drug because they metabolize the drug more slowly, they'll have a higher amount of the drug in their circulatory system. So they'll need a lower amount of the drug. And essentially this is what pharmacogenomics aims to do, is to try and tailor medical treatments and the dose of a medicine based on the genetic architecture of genes that encode for enzymes that are involved in metabolism. Certainly it's a rapidly expanding area of precision medicine. Another reason why drugs are sometimes not very good is I mentioned that some drugs are now produced in living cells through recombinant DNA technology, for example, recombinant proteins and antibodies. Well, when these are antibodies and these proteins are injected into patients, the patient's immune system can often recognize these proteins and neutralize them and result in their clearance from the body. So what you get is anti-drug antibodies being produced by the person against the actual drug. So they're actually neutralizing the drug. And that is why some people do not benefit from some of these therapies. It does explain that to a large extent. And really, the last point I want to make here is why some people respond to drugs and some people do not respond to the same drug is that there are molecular subtypes of disease existing in patients with apparently the same condition. So if we think of breast cancer is not just one disease, but there are a number of subtypes of breast cancer. We now have very good proof, and this has been exploited clinically, whereby the type of breast cancer a person has dictates the type of treatment that they will get through molecular analysis. And really what our course covers is a lot of this, is that knowing that within a particular disease such as cancer, and then drilling down into breast cancer, breast cancer is not just one disease, it's made up of a number of different subtypes, and that you need to treat those subtypes in an individual basis rather than just treating breast cancer as a whole. And I'm going to give you a bit more information about this in terms of historical origins of precision medicine, because it can be traced back most likely to breast cancer, and us knowing that breast cancer is not a single disease, but in fact is comprised of a number of molecular subtypes. And really this can be traced back to the late 1800s, when the surgeon, George Beatson, he was a surgeon working up in Scotland at the time, and he was working on treatments for breast cancer. And what he learned from the Scottish farmers in the Highlands up there was that there was a link between the ovaries in an animal and essentially the mammary glands. And what the Scottish farmers noticed was that if you took out the ovaries of an animal, that their mammary glands changed in terms of their properties, in terms of milk production, etc. And what he did at the time, George Beatson, in the late 1800s, was he had 3 women who presented to his surgery with breast cancer. And what he decided to do was, he knew that there was a link between the ovaries and the breast based on those animal studies from the Scottish farmers in the Highlands. He removed the ovaries from these 3 women with breast cancer. And what he noted was that their tumors shrunk dramatically, okay? So taking out the ovaries from these 3 women led to dramatic reductions in their tumor volume in the breast. So there was some signals or something coming from the ovaries that was been released and was seemed to be driving the breast cancers in these three women. He wrote this up in a paper, and other surgeons in England started to try and repeat these studies. Now, what they found was that it would work for some women with breast cancer, but it didn't work for every woman with breast cancer, removing their ovaries. And this became known as Beatson's riddle. Okay, so why do some women benefit from removing their ovaries as a treatment for breast cancer versus other women with breast cancer who do not respond to this treatment? And what we now know through molecular analysis and advances in cellular and molecular biology is that the ovaries are producing a hormone called estrogen. The ovaries produce a hormone called estrogen, which goes into the person's blood, and that estrogen hormone attaches onto the estrogen receptor on the breast tissue, and that can drive unregulated proliferation and may lead to breast cancer in a subset of patients. There's a second receptor called progesterone, which is also, its receptor is found on the breast tissue as well. So you have 2 receptors, 2 hormone receptors, the estrogen receptor and the progesterone receptor. And when these are expressed highly on the breast tissue, their ligands, the estrogen and the progesterone, estrogen coming from the ovary, can lead to increased proliferation of the breast tissue and lead to breast cancer. And so what a lot of treatments do now to treat this type of breast cancer is to block this estrogen signaling coming from the ovaries. And that is why for some women, they may have their ovaries removed as a potential treatment for breast cancer. It's not widely used. There are other types of drugs that block this estrogen signaling in breast cancer. So this was really the first treatments to come out for breast cancer, which were not chemotherapy. And then we knew that there were different molecular subtypes of breast cancer in the mid-1980s when the US oncologist, Dr. Dennis Slayman, he discovered that a subset of women with breast cancer did not have the estrogen and progesterone hormones driving a subset of breast cancers. And that there's another subset of breast cancers he was studying, which he found were highly aggressive, and that women who had this type of breast cancer had a shorter survival, and their tumors came back more and more quickly because these tumors were more aggressive. And he characterized the molecular basis of this subtype of breast cancer. And he discovered that in this subset of breast cancers, there was a gene called HER2 gene, and that this HER2 gene is amplified So that rather than having just 2 copies of the HER2 gene, women with this subtype of breast cancer have up to 50 copies of the HER2 gene. And because the HER2 gene encodes the HER2 protein, these women had too much of the HER2 protein on the surface of their breast tissue, and that was leading to increased proliferation of the breast tissue and giving this highly aggressive subtype of breast cancer. In other women, they didn't have up to 50 copies of the HER2 gene. Sometimes they just had too much overexpression of that protein on the surface of the tissue, leading to increased proliferation and shorter survival times. So this really started to open up the molecular era in breast cancer, and that we didn't just have one type of breast cancer here, but we had a number of molecular subtypes. We have the hormone receptor positive subtype, which essentially you have between 50 and 2/3 of all breast cancers are driven by hormone receptor based cancers. And then you have the HER2 amplified breast cancers, which constitute between 15 to 20% of all breast cancers. And we actually have a third subtype then, which neither expresses the hormone receptors. That is, it doesn't express the estrogen or progesterone receptor in the breast tissue, or the HER2 pathway is not amplified. And this third subtype is known as triple negative breast cancer. So essentially to date, we have 3 types of breast cancer. And essentially what has come from this new knowledge in science is that the breast cancers are treated completely differently. So the ones on the left are treated completely differently from the ones on the right. And that is shown here, that if a person is diagnosed with breast cancer, one of the first things that is done is what molecular subtype of breast cancer is it? Is it hormone receptor positive breast cancer? And if it is, then the patient is administered one of a number of different therapies, which essentially block that hormone signaling in the breast tissue. And this leads to very good outcomes for this subset of breast cancers, which I mentioned constitute between 50 and 2/3 of all breast cancers. Whereas if a person is diagnosed as being HER2 amplified or overexpressing breast cancer, they get a completely different set of drugs to target that HER2 protein on the surface of the breast, which gives them the best outcome for their disease. And there's quite a number of these now that have been clinically approved both in the United States and in Europe and indeed throughout the world. So really one of the main things that is done now is that when a person is first diagnosed with breast cancer is you need to determine what is the subtype of breast cancer. Is it hormone receptor positive breast cancer, or is it HER2 amplified, or indeed is it triple negative, that it neither expresses either of these pathways. And so what is key to this knowledge in science is inaccurate diagnosis. This is where the diagnostics come in. And one of the routine ways of analyzing whether the estrogen receptor is expressed on the breast tumor is to take a biopsy, and antibodies are added which are specific for the estrogen receptor, shown here, and they light up the tissue as being brown if the estrogen receptor is expressed on the breast tissue here. So this particular patient is estrogen receptor positive, so they will get these particular type of therapies I mentioned on the previous slide on the left. Whereas if the patient is ER negative, the estrogen receptor is not been expressed here, they will be tested for HER2, for example. And over on the right here shows tissue staining that is HER2 positive or HER2 overexpressing. And again, a biopsy is taken and it is stained with antibodies which bind to the HER2 protein on the outside of the cell. And they light up the tissue as being brown here. You can see that brown staining. So this is a classic HER2 positive diagnosis. So this patient then would get the different gamut of HER2 targeted agents, which have now been clinically approved, which gives them the best outcome for their disease. So this antibody-based staining is routinely used to diagnose HER2 positive breast cancers, or we can look at the actual gene itself. I mentioned that the HER2 gene encodes the HER2 protein. This is the protein on the top. This is the gene on the bottom. So to look at the actual numbers of copies of the HER2 gene, we use a technique called in situ hybridization. And the red dots here are red DNA probes which bind to the HER2 gene. So you can see inside each cell, rather than having 2 copies of the HER2 gene, you have multiple copies of HER2. So this is a classic HER2 amplified breast cancer. And in green, there you have basically a control gene. which shows that, you only have 2 copies of the control gene, but multiple copies of the HER2, which shows that this breast tumor is overexpressing the HER2 gene, leading to increased HER2 protein expression on the surface up here. And as I mentioned, that then really is the key in precision medicine, is diagnosing diseases and conditions more accurately. So is it hormone receptor positive breast cancer, or is it HER2 amplified breast cancer? And with that then, a treatment is applied to the patient, be it treatments that target the hormone driven pathway or the HER2 driven pathway. And so where we are today in terms of breast cancer and precision medicine, precision oncology, is that you will have a population of patients with breast cancer. They're heterogeneous in that there's subtypes of disease in here. The aim is to stratify those patients into different cohorts and treat them then with drugs which give them the best outcome for their disease. So be it hormone receptor positive breast cancer, they get a completely different type of therapy than HER2 amplified breast cancers. And the third subtype, as I mentioned, there's triple negative breast cancer, which up till recently was had a poor outcome in that these patients generally just got chemotherapy as well as surgery to treat their diseases. But now in the last year alone, there have been a couple of new treatments that have been clinically approved to treat triple negative breast cancer as well. So we're starting to drill down a lot more into the subtypes of disease. And here I've been using breast cancer as an example. So using an accurate diagnosis, looking at the molecular diagnostics of their disease and stratifying patients then into different subgroups and treating them with different sets of drugs. So more in a precision medicine approach or personalized approach here. And the goal here, really what you're doing here is you're stratifying the patients into those who are more likely to respond to a therapy are identified in treatment and treated. So there's no point giving a person with hormone receptor positive breast cancer treating them with HER2 targeting drugs, because most likely they will not work. And so really what precision medicine is advances in science. So looking down into the molecular details of a cell, and looking at what's gone wrong within the cell. And of course we need primary research and basic research to understand that. We're marrying that science with advances in technology. So advances in diagnostics, using molecular probes and using antibodies to basically diagnose diseases and conditions more accurately, and then applying both the science and the technology to medicine. Okay, so to give patients a better outcome for their disease or condition. And really that's the goal of precision medicine, to hit the actual disease right where it hurts and to come up with the best cures for individual patients, rather than treating patients as an average population, which we know doesn't always work. And breast cancer is not the only example I can give you. So metastatic melanoma, this is the most deadliest form of skin cancer. This is a mole or a melanoma, an advanced mole essentially, which is turned into a melanoma, uncontrolled proliferation of melanocytes, which are found in the skin. They're forming a tumor here. And if left unchecked in the skin, these tumors can break off into the circulation and seed a number of distant organs around the body. If that happens, the patient usually has a very poor outcome, unfortunately. That's why it's the most deadliest form of skin cancer. And in 2002, sequencing of a large cohort of tumors, including melanomas, found out essentially that about 50% of all the skin melanomas, so cutaneous melanomas, about 50% of them were driven by a mutation in a gene called BRAF. Now, the normal role of BRAF is, when it's transcribed and translated into a protein, is that it regulates cell proliferation. It allows the cell to divide. And what they found in these melanomas, about 50% of them, was that this BRAF gene was mutated. Okay, so rather than having a valine at position 600 of the protein, we had a glutamic acid or a lysine, which was essentially making a mutant BRAF protein and was causing uncontrolled proliferation in the cell, which is driving this aggressive subtype of melanoma. And on the other hand, you had the 50% of patients with the BRAF gene, which was wild type. Okay, so this gene was not mutated in this cohort. And a company called Plexicon Biosciences came up with a small molecule drug called vemurafenib to treat this mutant BRAF, because their small molecule drug fits into the BRAF protein when it's mutated in here and essentially blocks it from driving this proliferation signal into the tumors. And these are some of the early clinical trials. A patient on the left here before treatment. Again, it's a scan. You can see the melanomas have formed all over the person's body. Look at the body cavity here. And just 2 weeks after vemurafenib treatment, you can see the tumors have dramatically melted away, because that small molecule drug, vemurafenib, is sitting into this BRAF mutant protein and stopping it from signaling and leading to cell death of the tumors. And again, this is patient 2 here, similar story on the right, dramatic reduction in tumor mass within this patient. So here you're looking at advances in science again to characterize the molecular pathways that have gone wrong between normal and disease states, coming up with a diagnostic assay to look for that mutation. This particular diagnostic assay here is a PCR-based assay, and then coming up with a novel therapy to treat this cohort of patients with this BRAF mutation. Now, these are dramatic responses here in these metastatic melanomas. Sadly, what we often see with these type of drugs is that resistance occurs and that the tumors can get around being treated with this vemurafenib and come up with activate other pathways in compensation and bypass this block by the drug and come up with novel ways to keep on growing. So we often see these tumors coming back. But thankfully, drug companies such as Plexicon have come up with additional drugs, more effective drugs, and indeed combinations of drugs to block these additional pathways. And these have been shown in clinical trials, and these drugs have now been clinically approved to lead to increased patient survival and a better outcome for patients with melanoma, which has spread to distant body cavities, as shown here. And again, it's a similar story and successful story in lung cancer, whereas when a person is diagnosed with lung cancer, traditionally a biopsy will be taken and a pathologist will stain the tissue, and they will classify the disease as being small cell lung cancer based on the size and the type of cells found in the tumor, or they may diagnose the lung cancer as non-small cell lung cancer. Okay, so you have small cell lung cancer or non-small cell lung cancer. And then over the last 15, 20 years, the molecular analysis of these, particularly non-small cell lung cancers, have found that it's not just a single disease, or it's not just a subtype of lung cancer, but in different patients, they have different molecular aberrations in their tumors. So we now know a cohort of patients with non-small cell lung cancer that their tumors are driven by mutations in a gene called epidermal growth factor receptor. That gene, when it's transcribed and translated into protein, gives this EGFR protein. So when it's mutated, it causes too much proliferation in these non-small cell lung cancers and driving a distinct type of tumor growth. Whereas another subset of patients, about 3 to 7% of patients, do not have mutations in the EGFR gene, but they have a different genetic aberration. They have a gene called ALK, which is inverted in their tumors, and it becomes fused with other genes, partner genes, and again drives a completely distinct type of non-small cell lung cancer. And likewise, you have ROS1 translocations and BRAF mutations, for example. And these 4 types of mutations tend to be mutually exclusive, so that a person with an EGFR mutation generally does not have an ALK gene mutation and does not have a ROS1 translocation or a BRAF mutation. So what is happening now is that there are now very good effective drugs to treat these subtypes of non-small cell lung cancer. So again, we're going back to advances in science, showing that lung cancers are not all the same, that there's different subtypes of disease as shown here, and that you need an accurate diagnostic assay to pick up these mutations or gene rearrangements here for ALK, or look at the ROS1 translocation. And with that, then you can come up with novel therapies. So for example, these 4 subtypes of non-small cell lung cancer are treated completely differently from one another. And these treatments have been shown to give the best outcome for patients. So they live longer on these particular therapies. Their tumors are controlled better, for example. So it really is showing how we can marry science, technology, and medicine together to give the best outcomes for patients, and away from the one-size-fits-all approach to lung cancer, which generally would be, again, like chemotherapy. And just in the last couple of months, I've added there's been more advances again, where in non-small cell lung cancer, they found new aberrations for subsets of patients. There's a gene fusion encoding the RET gene fusing with another fusion partner, which can drive another subset of non-small cell lung cancer, or indeed a distinct subtype where you have a gene called MET, and there's the exon 14 is skipped, so you get this shortened protein, MET protein, being produced, which again drives a completely different subtype of non-small cell lung cancer. So there's new therapies out to target these as well. So as time goes on, we're drilling down more and more into the molecular basis of diseases. We're getting a better handle as to what's driving these diseases. We come up with a diagnostic assay to diagnose these subtypes of disease, and with that, design novel therapies which will give the best outcome to subsets of patients. So this is essentially what precision medicine is. We're targeting the aberrant pathway in that person's tumor rather than the population's tumor. And this is leading to a tailored approach. And it certainly is an alternative to the one-size-fits-all, where everybody with a particular tumor type gets the same treatment. And it avoids the trial and error approach as well, whereby a drug may be trialed on a patient, it doesn't work, they'll have to go on a different therapy again. And if we take that back to cancer, all this time the patient is on a treatment that doesn't work for them, their tumors are probably growing and getting worse at the same time, which is not what you want to do. These new targeted drugs, which target specific sub-cohorts of patients, have been shown through clinical trials to lead to increased patient survival, so the person lives longer. And for many of the cancers I've just spoken about, primarily lung cancer and melanoma, these targeted therapies, such as small molecule drugs or indeed antibodies, they've replaced chemotherapy as the first line therapy. So, and it's important to say we're not really throwing away chemotherapy either. Chemotherapy has now been moved down the list as the first line treatment. So we know the targeted therapies are better because they target the precise pathway that has gone wrong in that person's tumor. And so you're often, in many cases, avoiding the use of chemotherapy. And of course, with that, you have less side effects, because anybody who knows anything about chemotherapy is these are drugs which target both tumor cells, but also healthy cells as well. And that's why you get the nausea and the hair loss and the skin problems. So using targeted therapies is generally better than chemotherapy. And this essentially is precision medicine. And there's some really, really exciting advances in precision medicine as well, because as I mentioned, when therapeutic drugs are first approved, either in the United States by the Food and Drug Administration or in Europe by the European Medicines Agency, they generally are, from a traditional viewpoint, approved for subtypes of cancer. So you may get a new drug been approved for lung cancer, or a new drug been approved for colon cancer, for example, or indeed a different type of drug been approved for breast cancer. That is because in that trial, all those patients had breast cancer or lung cancer, for example. What we've seen in the last couple of years is that we're now seeing tumors being treated not according to where they're located in the body, be it the breast or the lung, but they've been treated according to the molecular aberration within that tumor. And in the last 2-3 years, for example, the Food and Drug Administration, and Europe is now following suit, have approved some therapies not based on where the tumor is located, but based on the molecular aberration. So, for example, this antibody called pembrolizumab is now clinically approved to treat any tumor, any cancer type, be it the breast, the skin, or the colon, or the lung, wherever, the brain tumor, if they have this particular genetic signature. This is tumor mutational burden. If a tumor has a very high number of mutations, and this is detected by sequencing of the tumor, if it has a high number of mutations, it's very likely to respond to this drug called pembrolizumab. Okay, and so that drug is now clinically approved to treat these types of cancers. So it doesn't really matter where the tumor is located now. It's key to sequence the tumor and find out if it has this tumor mutational burden high signature. If it does, the tumor is likely to respond to pembrolizumab. We also have a couple of drugs, entrectinib and larotrectinib, which target this gene fusion encoding this NTRK gene. It gets fused to a partner gene which drives proliferation in various cancers. NTRK gene fusions are found they're quite rare in tumors, between 1 and 2% of tumors express these, but these tumors respond very, very well to these drugs. So if a person now has breast cancer or lung cancer or colon cancer, it's going to be key to diagnose the molecular aberrations within these tumors, because they may have this NTRK gene fusion and respond very, very well to these targeted drugs shown here. Okay, and this is what we're seeing now, a shift away as well as in the use of targeted drugs for just being restricted to a type of cancer tissue, and being given to being approved for any cancer at all. And as well as that, in terms of cancer, we know that cancer is not driven usually by a single gene, and that cancers and tumors of the breast or the colon or the lung, what have you, generally you have tens, if not hundreds, of genes which are mutated. And so to treat these tumors better, we need to get a better handle on what are all the molecular pathways that have gone wrong. So we don't just test for one gene like the HER2 gene or the epidermal growth factor receptor. Where we're seeing a shift away now is we're using multi-gene panels, where through sequencing, we can now sequence a whole cohort of genes which are known to be mutated in cancer, and to basically sequence a particular tumor and find out what pathways have gone wrong with it, and with that, be able to direct appropriate therapies for subsets of patients that will give them the best outcome for their disease. And one of these now been clinically approved in the States is the Foundation 1 CDX diagnostic assay, which uses next generation sequencing to determine the basically the sequence of hundreds of genes which are known to be mutated in cancer. Another very exciting area of cancer diagnosis, particularly for solid tumors, is the clinical approval of liquid biopsies. So if a person is diagnosed with cancer at the outset and it's a solid tumor, be it the breast or the lung, essentially a biopsy is done whereby a small sample of cells are removed, typically through a needle or a syringe. They're siphoned out, and those cells are brought to a pathology lab, and they are analyzed for the molecular aberration, be it HER2 overexpression in breast cancer or the EGFR mutation in lung cancer. Now, when these patients have these tumors, they may be old, they may be frail, they may have had chemotherapy already, so they may not be able to withstand a standard biopsy. And so it's very invasive for the patient in terms of getting a needle into their tumor and extracting those cells out. There's a lot of pain involved. As I mentioned, it's invasive. It's not easy to sample or take a biopsy from a tumor mass. And there's also the question of, if you take just a few cells out of the tumor mass, are you seeing the whole picture of what is actually going wrong in terms of molecular pathways in that tumor? And so we're moving towards liquid biopsies now, whereby we know that solid cancers, be it breast cancer and lung cancer, they can shed tumor cells into the blood. And so we can now do a quick blood draw from the person and detect the cancer cells. We look at the cancer DNA in the blood sample, and we can do sequencing to find out what mutations are present in the tumor cell. Although we're looking at the blood, we can refer that back to the actual solid tumor where that tumors come from, and find out what pathways have gone wrong, and then direct appropriate therapies for that patient without having to go into the solid tumor mass here. So this is quick. It's done by a simple blood draw. You can get a comprehensive tissue profile. You're not just looking at a few cells from one corner of the tumor. You're looking at the blood. So how much homogeneous population of cancer cells in the blood probably give you a better representation of the pathways which have gone wrong in the actual primary tumor. Very easy to obtain a blood draw, minimal pain or risk involved in doing a blood draw as compared to an invasive biopsy. And it is invasive, as I mentioned. So this is where we're seeing diagnostics going as well, more towards liquid biopsies rather than standard biopsies. So a very exciting area of precision medicine as well, better diagnostic capability. So I have to ask then, I suppose without the question, that as in precision medicine we have it all sorted, and isn't that right? Sadly, that's not the case at all. I mentioned a lot of these exciting new therapies which have now been clinically approved in the United States and indeed in Europe. These drugs are generally first administered to patients or approved for patients with end-stage cancers. And there's a very good reason for that, is that these patients have very few options left. They probably have undergone chemotherapy already, no other therapies to treat them with. So these patients are recruited into trials, clinical trials, and the new drugs are tested in these cohorts of patients to see if they give any benefit. And if they do, the drug is just approved for these end-stage tumors, so tumors that have already spread to other parts of the body, for example. And even if you get a benefit of, a few months extra survival rate, that can lead to the drug being approved, because we're always trying to keep patients alive longer and longer. So, a problem with that then is end-stage patients, or patients who have very advanced tumors, they tend to only have short-term responses to these new therapies, even when the drugs are tailored for these patients based on the molecular pathways. So disease resistance inevitably occurs. So we need to come up with better ways of looking at how the tumor is evading this new drug we've given them, and coming up with other angles to come and attack the tumor again, to keep patients alive for longer. So we certainly could do better in that response, as well as looking at disease resistance and looking at the new pathways which have now kicked in the tumor to resist the actions of our therapeutic drug. And in terms of precision medicine, we have a lot more to do as well. There's a very exciting cohort of drugs out there now called checkpoint inhibitors. And these are essentially antibodies which allow your own immune cells to go and attack tumors. And for subsets of patients, they've had absolutely miracle cures. These are patients with end-stage disease, stage 4 cancer, which is spread all over their body, such as melanoma. Generally, it's a dismal outcome for these patients. But with the checkpoint inhibitors, for about between 5 and 20% of patients, we can see cures with these drugs. However, at the moment, we don't have a good way of predicting which patient, when they're given this checkpoint inhibitor, will they respond and get a response? Will you see a tumor shrinkage, and or will you even see a cure? And which patient who gets the same therapy, the same disease, they get the same therapy, but they won't respond. So we need to drill down into these patients' disease better and find out, can we predict which patient is going to respond to a checkpoint inhibitor and which patient will not. So we certainly can do better in that regard as well. And secondly, I've talked so far about precision medicine and its role in oncology, and there's a very good reason I'm focusing on oncology in this talk today, and that's primarily because most of the significant advances in precision medicine have been in oncology. But certainly where we're seeing precision medicine being applied now is to other diseases and conditions, such as inflammatory conditions. And we'll go back to, give you this example here. This is a person with psoriasis, which is an inflammatory disorder of the skin. You get this red patchy skin here. What is essentially happening is the person's immune system in their skin is releasing inflammatory cytokines, which is signaling to the keratinocytes in the person's skin to proliferate more, and you get this red patchiness. And essentially the standard of care for people who have severe psoriasis is an antibody therapy called anti-TNF therapy. There's quite a few of these now clinically approved to mop up the inflammatory TNF alpha molecule. It works for quite a percentage of patients. However, it doesn't work for everybody with psoriasis. And you'll see this person was treated with the anti-TNF therapy for their psoriasis, and they actually had no response. This here is the baseline treatment. So this is actually after they were treated with anti-TNF. You still see the inflammation in their skin. Then what happened was they were treated with a new FDA-approved drug, which rather than targeting the TNF alpha inflammatory cytokine, essentially targets T cells, which are driving the inflammation in psoriasis. And you can see after 3 months of this treatment that psoriasis, this is the same patient, top and bottom. After 3 months, you can see the complete clearance of these plaques, these red scaly plaques in this patient. So this shows you that essentially psoriasis, we would typically, like cancer, traditionally would have seen it as the same disease. We see subtypes of psoriasis now because we see these psoriasis responding to different drugs. This one doesn't respond to standard anti-TNF alpha therapy up here. So it's been driven by a different molecular pathway, primarily involving T cells down here. And at the moment, clinicians and dermatologists who treat psoriasis, there's no way of predicting which drug will benefit a patient with psoriasis. So patients with psoriasis tend to go on this, this treatment odyssey, whereby one treatment is tried, like this patient above here, try them with standard anti-TNF alpha therapy, see does it work. If it doesn't work, let's try another therapy and hope that it works. And in this case, this is a positive outcome down here, but maybe some patients don't respond to these T-cell targeting drugs down here, and they have to go on again to this roundabout of different therapies. So we need to do much better at trying to define therapeutic strategies for patients with inflammatory diseases. So we're talking psoriasis here, we're talking rheumatoid arthritis, we're talking inflammatory bowel disease, and we're talking multiple sclerosis are just some of the examples we cover in our course as to how we can come up with better ways of targeting subtypes of inflammatory diseases and conditions. So, and essentially that's my pitch to you today, is that in terms of precision medicine, which is, you know, exploiting advances in science, technology, and medicine, we need you. We need the best scientists, we need the best diagnostic technologists, and we need the best clinicians really to come together and work together to drill down into the molecular basis of diseases and conditions and come up with better diagnostic assays and apply them to patients more accurately to give the best outcome for patients. So as I mentioned, that's what our course essentially deals with, and that was essentially an overview of what our master's course is all about. So now I'm going to switch gears and tell you a little bit of how our course is structured and how we deliver it and how it's assessed. First of all, in DCU, we deliver most of the modules in DCU. However, 3 modules are delivered by our partners at Arizona State University in the United States and through the International School of Biomedical Diagnostics. So we have international collaboration with Arizona State University. So both of us are involved in delivering our novel master's program. I mentioned that our program at the start is delivered via hybrid learning, and this enables flexibility. So you may ask, what is hybrid learning? Well, essentially, this is a mix of both face-to-face teaching and online learning. Now, generally, under most years, we deliver our course through hybrid learning. And this is involved a mix of classroom delivery. So you'll see me down here in a lecture room giving a lecture on multiple sclerosis. And what we do is we deliver the lecture in the classroom. So students who want to come to class can come and sit in the classroom. But we also record the lecture. So if you can't come to class, or maybe you're an international student, or maybe you're working in an industry full-time, and you're doing our course part-time, you can't commit to coming to DCU on a Wednesday or a Friday afternoon to come to the lectures. We record the lectures for you, and we put them up on our online learning platform called Loop for you to access those recorded lectures. And the beauty of that is you can watch these lectures in your own time. So that's where the flexibility comes in. You can go back and rewind the lectures or go to a specific site in the lecture. And we all know when you're attending a classroom-based lecture, you know, you're not going to remember everything. So having the recorded lectures is great for revision. And we actually see higher marks in our assessments, you know, because our students often tell us that, you know, they really liked having the ability to go back and revisit the material, or re-listen to what something the lecturer said at a particular point in time. So we have classroom-led lectures, workshops, and tutorials from DCU. And we also have our lectures from Arizona State University, as I mentioned. Now, these are all online. You can't attend these in person, obviously. These are online lectures delivered by our colleagues there. We have 3 modules which are online, delivered by ASU. This is what normally happens. However, for semester 1 this year, starting this October 5th, we have online delivery of lectures only for semester 1 due to the COVID-19 pandemic and the need for social distancing. So DCU is, where possible, avoiding bringing students on campus to try and keep infection control as low as possible. So we're delivering everything online for you in semester 1. People have asked me what is going to happen in semester 2 and beyond. The university hasn't made a decision on that yet, but I can let you know as soon as I hear. But just to note that online delivery for semester 1 only. No option of coming to class in DCU at that time. And in terms of our course structure, it's divided up into 3 semesters. Semester 1 runs for 10 weeks, starting October 5th until December. Then semester 2 runs for 12 weeks from late January until April. And then we have semester 3, we call it our summer semester, runs for 12 weeks between May and August. So if you're doing the course full-time over a 1 year period, you will be doing all these semesters into 1 year. Whereas if you're doing the course part-time, either over 2 years or 3 years or 4 years, you can select modules within each semester, you know, to suit your lifestyle and your work commitments or other commitments in your life, family commitments, etc. So I want to go through the different semesters now. Semester 1 is a taught semester, and we have 5 modules in the program. The first module is Introduction to Cell Biology and Biotechnology. I teach that module. It's 5 ECTS credits, and that means 125 hours of learning between both lectures and dedication to assignments and self-directed learning. In this module, I give you a broad overview of the cell and the molecular biology in the cell, including genetics. And I will then tell you how this knowledge in molecular and cellular biology has been exploited by the biotechnology industry to manipulate DNA sequences and manipulate genes and insert those genes into host cells to transcribe and translate that gene into a therapeutic protein, such as a recombinant protein or an antibody, and come up with novel therapies. We have a second module then called Recombinant DNA Technology, which again ties very closely to the first one. And this is whereby we cover the different techniques and tools whereby you can manipulate genetic sequences and host cells that produce the drug for you through biotechnology to come up with novel ways of producing drugs. And so these 2 modules would tie in very nicely with biopharma, the biopharmaceutical industry. I also deliver a module called Fundamental and Applied Immunology. Immunology is really a central component of precision medicine, and it's also a very component, both cancer therapy, but also treating inflammatory diseases. So I cover this. I'm an immunologist by trade. So we cover the basics of the immune system and how we need an immune system to fight pathogens and microorganisms. And then in the latter half of the module, I talk about applied immunology, whereby we can manipulate the immune system to produce antibodies or indeed therapeutic cells to treat diseases such as cancer. Really exciting areas that have now been clinically approved in this field. So I cover that. We then have molecular diagnostics from Arizona State University. As I mentioned, this is completely online, delivered by our colleagues over there. We cover all of the molecular diagnostic techniques. Some of them I've already mentioned, like polymerase chain reaction, immunohistochemistry, in situ hybridization, gene sequencing, DNA and RNA sequencing, all of those key molecular diagnostic techniques. And finally, this all then really ties together in Precision Medicine 1, whereby we look at how advances in cellular and molecular biology and immunology and diagnostics all come together. You have science, technology, and medicine all coming together, and how cancers are being treated through precision medicine. So, you know, you see some great examples of that through breast cancer, chronic myeloid leukemia, lung cancer, melanoma, immunotherapy. We cover all of that. And you'll notice this is 10 ECTS credits, this module. So it's worth twice as much as the other 4 modules up here. So we put a lot of emphasis and weight on Precision Medicine 1 here. And that's your semester 1, delivered over 10 weeks from October to December. You come back then in late January for semester 2 for 12 weeks of lectures. Our first module is delivered by Arizona again, and that's translational bioinformatics. So it's how you look up bioinformatics databases and look at it. We can generate so much data now, and the problem is analyzing it as scientists. So we need to come up with computational methods to analyze all this new and exciting data and to apply that to patient treatment strategies. You'll learn all about that. Then we have applied biostatistics from Arizona State University as well. So once you generate data, you have to be able to do statistics on it. So you need to know what statistical tests to do on that to see whether it's significant, your treatment is significant. So you learn all about that through ASU. And I should mention here that while our 3 modules from ASU, that is molecular diagnostics and precision in semester 1, and the 2 modules here are delivered by ASU, we have tutorials run at DCU by our experts here and our academic leaders here to support these lectures at ASU as well. So, so we've really built that into our system in terms of student support at DCU. You'll then go on and do a module called Laboratory Techniques in Biomedical Diagnostics. This is actually a dry lab. You won't be going into the lab to do the actual techniques. We show you videos, and we actually, to show how these key techniques in molecular diagnostics are carried out. And then you're given raw data that has been generated in-house, and you then interpret that data and you write it up. And this is very important as well for learning how to analyze and critically analyze data for your research project, which happens in semester 3. We also have professional skills for scientists. So when you leave our course, you know, we want you to know all about precision medicine, but we want you to have a lot of transferable skills as well. So communication skills, writing skills, having a very important appreciation of research ethics, and indeed bioethics. You know, if we're doing something in precision medicine, is it ethical to do this? So you learn about all of this in the professional skills sector. We also have careers seminars built into this professional skills as well, which are not actually assessed, but they're built into your professional skills to allow you how to plan for your future careers. And then this all comes into, again, Precision Medicine 2, which I lecture in semester 2. Again, this is worth twice the number of credits as the previous 4 in the semester. And here we don't look at cancer at all. We look at how there's different diseases, like inflammatory diseases such as psoriasis, inflammatory bowel disease, multiple sclerosis, and rheumatoid arthritis are treated with the current range of therapeutic drugs, and how we need a better precision medicine approach here. We need to predict which patient needs an anti-TNF or which patient needs a T-cell targeting therapy to treat their psoriasis, and how can we come up with a better diagnostic assay to stratify patients to give them the best treatment outcome. And we also then cover how precision medicine has impacted inherited diseases. So we're looking at therapies that target aberrant genes, like, you know, gene therapy, or genes that manipulate messenger RNA that encode certain proteins. We can target these to treat a number of diseases. We also look at disease like cystic fibrosis as well, whereby you have a huge range of really exciting small molecule drugs to treat mutations in subsets of patients with cystic fibrosis as well. So very exciting in semester 2 as well. Then semester 3 is essentially the research project. And as part of your research project, you compile a literature review, a comprehensive literature review on a topic that you will be assigned. Then there will be a research project, what you will work on, and then a presentation. And this is worth 30 ECTS, so it's worth 1/3 of the whole course. And with that, you'll do a research project in a DCU laboratory, where you'll work on that project for 12 weeks full-time. However, if you are working in industry like the diagnostics industry or healthcare industry or in medicine, we allow you to take your project in your place of work, subject to some terms and conditions. Okay, so if you're doing our course part-time, you may be working in the diagnostics industry, for example, and you want to do our course part-time, you can do your project in your place of work, subject to some terms and conditions, which, you know, we can discuss at a later time. You can do it in your place of work, so that is going to benefit you in your workplace and indeed your employers. So again, that's a bit of flexibility built into the system. Our lectures are flexible. Our research project is flexible for those working in industry as well. We want our course, we have our course built around flexibility. In terms of how the course is then assessed, we don't have formal exams. You won't be sitting in an exam hall doing a 3-hour exam. We use continuous assessment to assess your learning and to show us that you're meeting the learning outcomes for each module. So here you'll see in semester 1, for example, what we've planned. You have your 5 modules shown here over the different weeks, week 1 to week 10. They're colored, the boxes are colored as to what weeks the modules run. And what you'll see is this continuous assessment. In that week 5 here of this module, you're due a short assignment worth 20% of the module in week 5. And then there's an online exam worth 40% of the module in week 9 to assess your learning up to that point. An online exam means you're going to log in at the same time onto our online learning loops, our system loop, and there'll be certain different types of questions and assessments built into that. And then you have a medium assignment worth 40% of the module due in early January. And that's our provisional timetable, which we've used in the last couple of years to assess your learning. And what you'll see in that your assessments that we do our best to avoid having too many assignments all together at the end, so we've spaced them out. We want you to engage continuously with the course over time, and that so it's not all riding on the one terminal exam at the end of semester, which is often done with a lot of undergraduate and indeed postgraduate courses. So how to apply? If you're interested, you can go to our website shown here. If you just Google MSc in Diagnostics and Precision Medicine DCU, that'll take you to the website as well. You'll see these different tabs here: introduction, what the program is about, why you should choose DCU, your careers, and then your requirement and fees. Here tells you how you can apply and the cutoff date for application. And these are the codes of the courses. So DC 739 is the full-time option over 1 year. DC 740 is the part-time option for up to 4 years. It says 2 years here on the website, but it is 4 years. My contact details are shown here again, and you can click on course fees should you wish to do that. What we require is that we require a second-class honours degree, so a 2-1 in a life sciences, a chemical sciences, a pharmaceutical sciences, or medical sciences. Backgrounds such as that, we require that. We also take people who have a 2-2 second-class honours if you have relevant industry experience. So if you're working in the diagnostics or the biopharmaceutical or the pharma sciences, you can apply, and we will make an assessment on your application based on that. So where most of our people come from is predominantly life sciences, but not strictly so. People come from chemistry as well, and pharmaceutical sciences, as well as medical as well. In terms of people from industry, we've people on the course from hospital laboratories, we've people coming from the biopharma industry, with people from the diagnostics industry. So a wide variety of people who are doing the course part-time, and they're working full-time, but fitting the course around their work. So that's where our demographic is. Our career prospects are obviously very important. Our graduates go into careers in the biopharmaceutical industry, the diagnostics industry, the clinical sector, including clinical trials companies. Some of our graduates have gone into academic and industrial research centres. So, a place like DCU or UCD or Trinity, where you do research, and some people go on to do PhDs afterwards. Some people go to the healthcare industry, and even graduate medicine. We've had some people who have done our course who have now gone into medicine to study medicine after they've done our course, which is great to see. And we hope they will continue precision medicine in their future careers. Just to finish up then, some testimonials, which really the proof of the pudding of why we feel our course is so successful. Here are some direct quotes. The first one is, the Masters was a thoroughly enjoyable course that provides students with up-to-date knowledge on current targeted therapies used in cancer and inflammatory diseases. This course provided me with the requisite knowledge to pursue a PhD in inflammatory disease directly relating to the research project which I undertook as part of this course. Participating in this program was the best decision I have ever made. 10 out of 10 would do it again. That was great. Second person said, I feel I have gained invaluable skills that will allow me to take my career to new heights. This program gave me the opportunity to advance my knowledge and expertise across a spectrum of scientific and statistical topics, opening up a wider range of career options in both academia and industry. I would highly recommend this course to anyone considering it. I always wanted to find a program that connects cancer, autoimmune and genetic-based diseases all together at once, and how individuals differ in their diagnosis as well as their response to a certain drug. I highly recommend this course. I want to pursue a career in precision medicine, diagnostics, or biopharma. And the last one is, this course is extremely interesting and up to date. It's in depth. It covers current and exciting areas in science. The lecturers were very supportive and available throughout semesters and provide all help possible. I really enjoyed this Masters and it's been a key stepping stone in my career. So it's great that we get feedback from all of our graduates as to what they thought of the course. And really, this is, we're really happy with the course so far to date. As I said, we're just going into our third year now. So if you are interested in knowing more about the course, do let me know. We have a postgraduate recruitment day this Thursday. So I will be online to answer any of your questions. you may have, or indeed feel free to email me directly. So without further ado, I will end this now.